Hello and welcome to the Royal College of GP's webinar on QOF QI, entitled QOF QI, Implementation of the Care of People with Learning Disabilities module. So we know that you're likely to already be familiar with the recent QOF changes. Now these give new opportunities to practices engaging in their own population-focused quality improvement, and they build on the prescribing safety and the end-of-life care modules from 2 years ago. So this is the third of a series of 4 webinars created to help you get the most out of quality improvement, particularly in this year's QOF. We are also hosting a similar webinar next week. That's Tuesday the 28th of September, also at 6:30, and that's covering the early diagnosis of cancer domain, the other one. So what can you expect to take away from this session? Well, hopefully loads, but in particular a few things. We want you to be familiar with QOF quality improvement in general, and we're going to include information on the 2021-2022 this year modules, and particularly what practices and PCNs need to do. We also want to provide a better understanding of the content of this module, and we want to give you a range of options about how to approach it, and we're going to support that by a variety of worked examples. And we also hope you will walk away knowing exactly where to look for resources which will support you and your practices and your PCN when you plan and when you carry out this quality improvement work. And specifically where to look for resources relating to LD, but also quality improvement in general. So before introducing our panel this evening, I briefly want to cover some housekeeping. We would like to make the video recording of this webinar available to people who are unable to attend tonight. So we're going to focus on the slides and the presentation in the first half, and we're going to respond to any questions you may have in the second half. So if you do have a question, please send it to us via the Q&A option on Zoom. We've disabled chat to ensure that we can easily moderate the questions coming in. We haven't disabled the hands up function, but we won't be using it this time as we want to focus on presenting the content to ensure a good flow, and so we stick to time. So if we do run out of time and we can't answer your question live, we will endeavour to follow up with you offline. So please do send questions for the Q&A later on throughout the presentations. Don't wait until the end, don't store them all up, but we will pick them up along the way and we'll read some out and answer as many as we can. You probably already know the answer to this. What is QOF and what is QI? Well, this year's QOF QI modules, they are early diagnosis of cancer, which we'll be discussing next week, and care of people with learning disabilities, which is why you're here. To support these and to support previous QOF QI modules, NHS England and Improvement, they commissioned the RCGP in collaboration with experts from other organisations, such as the Health Foundation, NICE, and Hull York Medical School, plus a huge range of learned colleagues, co-authors and contributors. We've done this since 2019, and we've produced 10 quality improvement modules for QOF, which will come out over the next 2 or 3 years. So why is quality improvement different to the old QOF, the tick boxing QOF? Well, practices this year and hopefully last year and the year before, practices are encouraged to understand where they have the potential to make quality improvements themselves, and then to design and to implement bespoke quality improvement plans. That includes identifying and assessing targets in order to address these. So what's different as well is that there aren't any deadlines given for either the completion of the diagnostic activities or deadlines for when to complete the plan, or deadlines for you to undertake your PCN meetings. So it's very much over to us in general practice. I appreciate it's September now, and we are probably halfway through the year. But for more information on the work, visit the links on the screen. So we can share slides after the webinar, so you have those and also other links. So the ones you can see include rcgp.org.uk/QOF and qiready.rcgp.org.uk. And then lastly, if you're on Twitter, you can find us holding Twitter chats and promoting resources there by searching for #QOFQI and @RCGP. So who am I? My name's Mike Jones. I'm a GP. I work in London. I'm currently leading the challenge of caretaking a small practice over in East London. I'm also the Deputy Medical Director of a large GP partnership in London, and I am a national clinical champion for quality improvement for the Royal College of GPs. I'd like to introduce you tonight to Dr. Sam Browning. Hi, Sam.
Hello. Hi. Hello, everybody. My name's Sam. I'm a GP. I'm based in Leeds. I've been a GP in Leeds for about 23 years. I'm the clinical lead for learning disability for Leeds CCG, and I've been doing that for about the last 9 years. And I'm also the GP working for with the learning disability health facilitation team in Leeds.
Thanks, Sam. So just to outline what we're going to do today, firstly, we're going to provide a quick summary of the module. Sam is then going to break down the various suggested areas for improvement, and we'll spend a little time addressing each, and we'll incorporate some evidence-based examples, and we'll refer to a wide range of existing local and national resources. And then we'll endeavour to answer all of your questions, or at least some of your questions, at the end in a Q&A format. So please do send in any questions as we go. So over to you, Sam.
Thank you. So obviously, learning disability being my area of special interest, I'm really keen that everybody across the whole country does as much LD QOF QI work as is feasible, but I'm acutely aware of the pressures that general practice is currently under, particularly made worse with the pandemic and so on. However, the stark stats reflecting the health inequalities that people with learning disabilities still face, it speaks for themselves. It speaks for itself, really, and it should be the only reason that we're doing what we're doing. It gives us the reason for taking action. People with learning disability are still dying 20 to 28 years earlier than the general population, often from preventable causes. So being mindful of the importance of the QOF QI work for people with learning disability and balancing that with the work pressures in general practice, I took on writing some guidance, particularly for Leeds practices, because that's where I am, taking a very pragmatic approach, focusing more on the resources and support side of things to try and make the process of the LD QOF QI work as less onerous as possible. It's not a very good phrase, but you know what I mean. Through this presentation, I'll take you through the guidance that I wrote and the resources that we offer. They're all free. If you go onto our website, anyone can download them. There's no charge, and we're happy for anybody to take them. Now, I just want to be clear that obviously that's not the only way of undertaking the LD QOF QI work. Please regard what I'm sharing with you today as simply an example. There will be lots of other areas in the country that are doing good work, and this is just really a way of describing what we decided to do in Leeds. So we looked at the key elements of the LD QOF QI and tried to pull those out. And really, it's about looking at the current quality of care that we're offering to patients on our LD registers and involving the whole practice team. That is key. It's not just GPs that have to take this work on. I think it's really important to recognise that practices will be at all different stages of the process and have very different populations with whom they're working. And I think we need to be clear that evidence of improvement for individual practices will be coming from very different starting points. The QOF QI recommends that we have, or asks that we have, 2 peer review meetings, and I think these should be very much facilitated to support shared learning and resource sharing. In Leeds, we decided that the first peer review meeting would be held to share baseline data and understand issues for practices, and talk about practice improvement targets. And then the second peer review meeting would focus on celebrating success, sharing changes, and how that's going to be embedded into everyday practice. So the one problem with that is that because the guidance that we put together was meant to be launched on the 3rd of June in Leeds, got delayed within the CCG. So as we move through the slides, you'll see certain target times like before the end of Q1. Clearly those aren't going to be able to happen now because of the delay in the documents going out. So we're going to have to tweak things, but that's just a Leeds-based issue. So as I say, we took a really pragmatic approach, and I tried to look at writing 6 suggested areas of improvement, which really just reflect the NHSEI expectations and the outcomes they will be evaluating. That's not to say all practices have to do all 6, and in fact, what we decided to say in Leeds is that we would ask practices to try and make sure they did area for improvement 1, 2, that should say, and 3 as a sort of baseline really. And if they have time to tackle 4, 5 and 6, then that's great. But again, it's about where you're starting from in your own individual practices. We wanted to make sure that the guidance we sent out to practices was heavily influenced by supporting information and signposting to resources to try and make the process as easy as we possibly could. To that end, we set out SMART aims for practices so that, again, they didn't have to do that for themselves. Clearly, practices can, if they wish to take a different aim, that's fine, but these are just suggestions to try and ease the process and make life as less stressful. So I'm going to summarise now in the next couple of slides the suggested or an overview of the areas of improvement that we came to in Leeds. These are the first 3, there's 3 more on the next slide, but what I'll do once I've gone through those is go through each point in more detail and signpost you to the resources relevant to that particular area of improvement. So in summary, the first 3, number 1, really straightforward, identify and name a lead clinician and a lead administrator for learning disability within your practice or PCN. Number 2 is very much concentrating around the learning disability register and identification of people with learning disability to make sure it's accurate and to make sure we're coding everybody of all ages with a learning disability, using the right searches to identify patients, using the inclusion tool, and making sure we're coding correctly. We use the OND Learning Disability Register code, so it doesn't actually matter what the underlying diagnosis is, and for some people there isn't one, it's just that everybody's coded appropriately. The third area of improvement would be on annual health checks themselves. We're always being asked to increase the number of annual health checks completed, so that's key. We should be ensuring that a health action plan is completed at every annual health check, and those 2 numbers should be equal, but they're frequently not when you look at data. And then I had a little thought about how to actually look at quality. It's quite a difficult thing to measure. We need to make sure that people are actually having a good quality annual health check, which includes a full physical examination and a formal medical review, a medication review, sorry. So what I did was I put together a couple of surveys, one for the use of patients, carers or care settings to be able to report their experiences, and another one for practices so that they can have some narrative around their own experiences as well. So the second slide on this is 4, 5 and 6. So number 4 seems quite straightforward to increase the number of flu vaccinations for people with LD, but actually there's a caveat to that in that we need to be making sure that we follow the Mental Capacity Act and best interest decision making processes correctly to make sure that we're not exempting people from vaccinations, whether it be flu or COVID for that matter, and ensuring that people are having the right access to the right treatment. Number 5, respond to the learning points from leaders. So this point is really about reasonable adjustments. If you look back at the recommendations from leader reviews, from the confidential inquiry and premature deaths for people with learning disability, and loads of different reports going back for years, all the recommendations come out around reasonable adjustments. So we've developed a reasonable adjustment alert, which is a form that we can fill out for every person on the LD register, and we're asking practices to do that for every person. And the final one will probably come out as one of the findings from the practice survey, identifying training needs for the whole practice team. That's right from receptionists all the way through to the clinicians who are actually delivering the annual health checks themselves. So now if we look a little bit more detail into each of the area of improvements, and there's not much in the way of resources for this first one, but there will be for some of the others as we move forward. So the nomination of lead practitioners, really straightforward. Some practices will already have this in place anyway. Nominate a clinical lead who will act as a point of contact, oversee the quality work, attend and share the outcomes of the peer review or network meetings. And then a lead administrator. This is key to success, I think. A clinician cannot do this work on their own. A lead administrator who can actually make sure that the practice achieves accessible standards by ensuring that you're using easy read documentation, can act as a point of contact for patients, support the clinicians with the searches and the coding and so on. I know from my own practice, it works really well. If you've got a lead administrator, it was a receptionist that took the job on in my practice, and actually she became the font of all knowledge, and patients got to know her well, and receptionists knew that if a patient phoned in, they'd be put straight on to Victoria, and Victoria often knew these people and knew what reasonable adjustments they needed. It just smoothed the whole process out. So the smart aim of this is really just to identify those two leads and share those names. We ask them to be shared with the Learning Disability Health Facilitation team by email. Again, the date might be changed, just because then as a health facilitation team, we know who to contact and who to offer training and support to if it's identified that it's required. So the next area of improvement is concentrating on the LD register and identification of patients with learning disability. You'll see, I mean, this reflects what the pack actually included when it goes out to practices in Leeds. There's a highlighted XXX. That there was for the CCGs to populate with practice-specific data, again, to try and take the pressure off individual practices, to give them the number of patients on their LD register currently, so they know where they're starting from. And then the smart aim is really to undertake a review of the register using the right searches, the guidance and the inclusion tool, all of which can be found on that link, which I'll show you a few examples on the next few slides. The idea of that is once you've done the searches is to then validate your register by ensuring the right codes are on the right patients and flagging the records in the system accordingly. That's to say that you'll be coding some patients who haven't been coded. You may be having to remove the code on patients who've been coded in error. So it might be that your disability register goes up or down or a bit of both. We've asked that the resulting number of patients on the validated registry is then shared with the CCG so that you can show what you've done. I think it's really important at this point to make sure that we put all patients of all ages and ethnic backgrounds on our learning disability registers. We know that the uptake of annual health checks is particularly low in young adults with learning disabilities, sort of 14 to 18-year-olds, and anybody of any age from ethnic minority backgrounds. I think it's really important to make sure we're identifying these people particularly. So again, support is available there on our website, and I'll go on to show you some of the documents that you'll be able to access if you do choose to have a look at our website. So this is our learning disability inclusion tool. It's not a diagnostic tool. You might have seen it before because it crops up in RCGP guidance and it crops up in NHSEI guidance as well. It is a checklist. As I say, it's not diagnostic. What is quite important though is there's a definition of learning disability included on it, because there's still a lot of confusion around that. We still see the term learning difficulty being used, and it's not the same, it's completely different. Please avoid using it. It drives me nuts. So a learning disability is a significantly reduced ability to understand new or complex information, learn new skills, cope independently, and it has to have started before adulthood and have a lasting effect on development. So if you run your searches in a practice and you've got your list of patients who may or may not have a learning disability, This is a tool that you can use to help you decide. Looking for certain things in their records. Did they attend any special schools? Were they statemented? Did they have any HCP? Are they known to any learning disability services? Are they under a learning disability psychiatrist? Are there some really awful old-fashioned codes and IQ measurements that you can find when you go back into their records? Has anyone ever told the person they've got a learning disability? What kind of qualifications do they have? We had, and probably still do have, a few people on various registers with Asperger's. Asperger's is not a learning disability. We've had people who are actually doing degrees at university on our learning disability registers. Clearly that's not right. Some people with autism have learning disability, but most don't. And then a little bit more about the person themselves. This might be things that you know about the person just by knowing them through seeing them in appointments and so on. And obviously it's not an exhaustive list, but it just gives you some pointers. So also you'll find all the searches in the document from NHSEI entitled Improving Identification of People with Learning Disability Guidance for General Practice. That was built, I think, from some work that the University of Leeds did on a diabetes project, trying to find out how to search for people with learning disability to be recruited into the research project. It's a really useful exercise, but it can be quite labour intensive, so you do need some support from an admin person. Again, in Leeds, and apologies for it being so Leeds-centric, we worked with the data quality team and the CCG to provide an LD user guide, because there are certain pitfalls that we all fall into, because most of us aren't particularly techie. It's around making sure that we've got the searches running properly, that we're coding correctly, that if you do find someone with a learning disability, you don't code on that day they've got a learning disability, that you backdate it to when it was diagnosed, because it skews the data completely. All our searches are embedded within our system, in System 1 and EMIS, and thanks to the data quality team. And I'm sure if you speak to your local teams, they can do something similar for you. Your QOF register should match your CQRS register. Frequently they don't, and it's often because of very small things that we're not doing right. So with your CQRS submissions, things have changed just recently. The collection frequency is now monthly. Data is automatically collected. You don't have to enter your register size anymore. That was one of the things that skewed the data. And the trouble is, if you're doing all this hard work and you're not putting your CQRS claims in, you're not getting recognised for what you do, because your numbers won't come up in the data. So please try and make sure that you are following the correct procedure for that, just from your own points of view. We need to be making sure we're using the right template for the Learning Disability Annual Health Check. In Leeds, we have it embedded within the system. It's accessed through the blue dot on the screen. In other areas, you may be doing something similar, and I would really recommend it because it makes life so much easier if it's just one click away. So, Area Improvement 3 is very much around the annual health check itself. So again, you'll see there's some highlighted X's, and that was for data to go in on for individual practices about how many annual health checks they undertook the previous year and how many health action plans were completed. Figures should be the same, but they're often not. So the smart aims here are really to increase progressively the percentage of eligible people on the LD register, so those 14 and over, having an annual health check, to reach, or even, if you're being super good, to exceed the national target of 75% by the end of Q4. And consider setting up a process of inviting patients on their birthday, so you try and spread the annual health check work throughout the year. That's not to say we're asking patients to come and celebrate their birthdays by having an annual health check, but I know in Leeds that there tends to be quite a steady amount of work going through Q1, 2 and 3, and there's a massive flurry in Q4. So if you've got the energy and the inclination, it would even things out if you take a slightly different tack of inviting people for their annual health checks. As I said before, one of the other key things is to make sure that we're all offering a health action plan at the end of every annual health check, and that's a requirement of the ES, so those figures should be the same. And then I thought a little bit more about the quality. That's where the surveys that I wrote, really they reflect the outcomes expected from, or the service specifications from the enhanced service around annual health checks. and also in the audit tool, which I'll talk about in a little while as well. We really want to know that the national template is being followed, and that a full physical examination is being undertaken by the right person, and a full medication review is being undertaken. We suggested that practices undertake this twice, maybe once at the beginning of the QOF process and once at the end, so that we can see if any issues that have cropped up for practices have been addressed, or how we can support the changes that need to be implemented. And then patient surveys are being filled out after as many of the annual health checks as possible, and being sent to the health facilitation team. I have to say, we're already getting some through, and there's some running recurring themes already cropping up in them, so it's quite interesting.
Sam?
Yeah?
Right, just before we go to the next slide, I just wanted to flag here that I think, I mean, this has already been going on in Leeds. How long have you been doing this for?
The surveys?
Well, all of this sort of quality improvement work in relation to LD, I suspect it's
about 9 years.
Exactly. I don't want people watching this to sort of worry about like the level of you know, competency they're expected to achieve within the remaining 6 months of the year. I do want people to remember that you are, you know, a special interest in patients with LD, that this work has been going on for almost a decade, that it is totally, you know, usable, borrowable, copyable, and I think what I'd just like to add in was before all the practices crack into these 1, 2, 3, 4, 5, 6 different areas for development, probably take a step back to start with and just think, right, wow, this is what's going on in Sam's practice or in Leeds, but actually what's going on in our practice already? How do we think we're doing? You know, do our patients think we deal with learning disability well? How do we think we do? And then if we think we're not perhaps achieving what we ought to achieve, what are the barriers? What's been holding us back? And why is this, you know, not currently feasible? So I did just want to just plot that in there, and before you start showing all these fantastic resources.
Yeah, no, I think that's a really good point to make. It has taken us a long time to get to the point that we're at in Leeds, and we're by no means perfect either. The health facilitation team, who are the ones that really work with me to put together all these resources, they were only developed on the back of a successful sequencing that we undertook in 2014 to 16. We didn't have a health facilitation team prior to that. So yes, any small changes based on what you already offer are positive changes, and you may be really, really good, but just doing it in a slightly different way. This is not one size fits all, and I am not saying that you have to do it this way. That's okay. So in order to help practices look at how to deliver a really good annual health check process, if you like, we put together this 10 steps to annual health check success. Annual health checks have been part of the NHS plan to improve outcomes for people with learning disability and reduce premature mortality since 2008. And they have actually been shown, there's evidence to show that they are successful in doing that. The enhanced service liaise, it concentrated on identification of people with learning disability, maintaining the registers, and offering a comprehensive annual health check, including a health action plan. Most of the requirements of the ES haven't changed since 2015. The payment increased in 2017-18, and the new electronic template was developed, which is now included in the updated RCGP guidance. So all of the things that are on this health checklist are part of that. So again, it's a focus on the whole practice. Everybody from receptionists all the way through all play a part in this. The read code searches are key on the document that was on a previous slide. The inclusion tool should be used, bearing in mind it's not diagnostic, but it helps you decide. Make sure that we're all using the right template. Please think about reasonable adjustments. The reasonable adjustment alert I'll discuss with you in a few minutes. Use an easy read invitation letter. There are 3 available on the website. They're a fillable PDF, so you can put your own practice details on it and make it your own. We've got information for families and paid carers about what to expect from an annual health check, so they can support their loved one or the person they're caring for appropriately when they're going for the appointment. We have an annual health checklist, which we send out to patients before they have their annual health check, so that they've got the time to go through things slowly, ask the same questions and all the things that are beyond the template for the annual health check. It just gives them a heads up, and also actually really helps you as a clinician when you come to it, because you can scan through and pick out any really important bits you need to focus on. Provide a health action plan. The template doesn't provide a particularly easy read one, but we have those on offer as well, and you can download those. And even if there's nothing that needs action for over the next year, still do a health action plan, but just so there's no health needs requiring follow-up in 2021. And then there is this quality checking measures document. It's an audit tool. It's an update of one that was published by the Learning Disability Observatory in 2011. It used to be called IHOW. And the surveys that I wrote kind of mirror the quality checking exercise within the audit. So you're almost auditing your own practice at the same time. So this is the survey. It was just my opinion of a survey, and we put it into easy read. All our documents are easy read, whether they be for, or in the same format, whether they be for professionals or for service users, simply because it's branded that way. And to be fair, I prefer easy read documents over complicated ones any day of the week. So this is the patient survey. We haven't asked for patient identifiable data, just an age and a gender. We have asked for the name of the GP practice, and that's really so that we can direct support and resources and try and work out if there's any themes in particular practices where they need specific input. It's asking whether or not the person received an easy read invitation, the easy read checklist before their appointment, how long their appointment was. Most of a decent annual health check is going to take 30 minutes, really. Did you have a full examination, a physical examination? It's not enough just to do height, weight, pulse and blood pressure. Did you have your urine checked? Did you have any blood tests you might need? Did you get a full review of your medication? Did the doctor or nurse talk to you about screening and vaccinations? Did you get a health action plan? And then just a few little questions, how was your experience overall? Did you feel listened to? And is there anything you think we can do to make your health check better?
Yeah, and Sam, so we spoke earlier about this, didn't we, about having both surveys for the patients and surveys for the staff. And actually, one of the next steps from this survey, I think, you're going to utilise the patients to co-design or to co-produce your sort of health check strategy going forward. Is that right?
Yes, yeah. As part of the health facilitation team, we have an involvement team as well, which has a lot of people, experts by experience, that we can access and tap into for their input. We also have a learning disability health task group, which we take documents like this to get feedback, and they're a very vocal group. And it's not just patients, there's carers, family carers, unpaid carers, and third sector people there as well. So we get quite a range of input. Because yes, you're right, we have designed this, and are we actually asking the right questions? That might be something that we need to explore with people who are experiencing it themselves, not what we think we want to know.
Yeah, and obviously practices up and down the country might not be fortunate enough to have these facilitation teams or patient involvement teams at this stage, but maybe this could be a trigger to start considering widening the scope of a PPG, or maybe working together with the PCN to sort of create a small focus group of, as you say, carers and service users together.
Absolutely. So this is the practice version of the survey. It's very, very similar, you'll see straight away. So we've asked just for practice name. And I think it's fair to ask practices to do it at least once, possibly at the beginning of the process and at the end, just from their own point of view, to see if any things have cropped up and that they've actually managed to tackle by the end of the QOF work. It's sending out easy read information, the booklet, how long was the appointment? Did you offer all the aspects of a comprehensive annual health check? Did you complete the reasonable adjustment alert? I'll do that in more detail in a few minutes. We're asking that everybody who has an annual health check or is on your learning disability register does have the reasonable adjustment alert completed. And then some individual practice kind of, I suppose, feedback. How confident are you in delivering? what examples have you got of things going really well? Because we need to celebrate those. It's not about beating people with a stick for getting it wrong. It's about celebrating the good things as well. Are there any specific issues which are hampering your attempts to try and deliver a full annual health check? And are there any specific areas where you need support? So that's where people like me can pick that up and work with the learning disability health facilitation team and the CCG to provide that support and that training. So area of improvement 4, like I said in the previous slide, it's about increasing the numbers of flu jabs being given. But for me, almost more importantly, it's about ensuring that we use the MCA properly and have a proper informed consent and best interest decision-making process under our belts. You can see there's a highlighted X so that we're getting practice-specific data out to people. And their smart aim is to increase the proportion of people with learning disability receiving the flu vaccination or declining it to a valid, documented, informed consent process. This has really been heightened, certainly in Leeds, around COVID vaccinations. We are aware that we've done quite well with COVID vaccinations in Leeds. I think we're over 86% for people with learning disability, but there were about 600 people that we were aware hadn't had even one vaccine. And we were following those up within our team, phoning patients, carers, etc. And it became apparent that there's quite a lot of parents making decisions on behalf of their 16 and over loved ones and declining having the vaccination. And awful 2 stories. We have had a 30-year-old and a 16-year-old in Leeds, both with Down syndrome, who weren't vaccinated because their parents said they didn't want the vaccination. Sadly, they both contracted COVID and they both passed away despite the best efforts of the hospital. So it's really key that we look at making sure we are documenting a good informed consent process and following the guidance from the MCA, otherwise we're not getting it right for these people. So to that end, we've developed a capacity assessment form. This one's specifically for flu, but there's nothing to stop people taking the principle and adopting it for COVID or for anything that you might need a capacity decision on. It's not specific to learning disability. It can be used for anything, people who have dementia, people who have severe mental illness. And it focuses on the keys of the Mental Capacity Act. So can the person understand the information being given to them about the decision? Can the person retain that information? Can they weigh that information up in the decision-making process? And can they communicate their decision? Obviously, we need to make sure we're giving people information in a format they can understand, so it's easy read information around flu. There's a part of the form there so that we can write down what the person's answers to those questions are, so we can demonstrate their capacity. They'd be often quite simple answers, but that doesn't matter so long as they can understand. And then there's a little part where we can put who's been involved in the decisions. And then there's a bit to say whether or not, you sign as a professional to say whether or not you feel that person does have the capacity to make that decision. Clearly, if they don't, we then need to move on to a best interest decisions meeting. So this is a consent form for flu, very straightforward: name, NHS number, date of birth, understanding the person's here to have their flu vaccination, that they understand what the information was and how it was given to them, that they would like to have the flu vaccination. And there's a bit there so they can change their mind and say no, even if they've got capacity. And then you can date it, give the vaccine, and then sign that you've given the vaccine to that person. If they don't have capacity, then we need to be thinking about a best interest decision making process, and it needs to be documented. I think we as GPs leave ourselves open to some serious criticism if we're not following this type of process for everybody and documenting it, particularly with the horrible COVID cases I was talking about a few minutes ago. So really this form just reminds us what to do. Obviously you have to have the patient's details, you need to have the people that you're consulting, so it's usually the carers or the parents or the people that know that person really well, other clinicians who know that person really well, and the clinician that's going to be taking or delivering that intervention. So it might be you who's giving the flu jab, it might be one of your nursing team that's giving the flu jab. Document the discussions you've had around supporting your decision and to why you might decide that it's in that person's best interest. summary of the decision which informs the outcome, the date, and usually it's a professional that will sign that best interest decision document, because it's you that's going to be giving the intervention for flu jab, for example. Okay, area of improvement number 5, really just around reasonable adjustments. I've spoken quite a lot about that already. It's on section 20 of the Equality Act imposes upon us a duty to offer reasonable adjustments to make sure that people with learning disability or any disability can access services. So what we've decided to do in Leeds, we've had the reasonable adjustment alert around for a while, but it's not widely used. We're asking that every practice does a reasonable adjustment alert or completes a reasonable adjustment alert for everybody on their LD register. It can be part of the annual health check, it can be done ad hoc, but the key is to save it to the records and flag it on the system and share it. You know, when you're doing a referral, share it with the hospital. If the patient's going into hospital, put it in the letter with them so that everybody knows what that person's individual needs are. This is what it looks like. They're often really, really small changes, really subtle things. And people like me who do a lot of learning disability work, they're a bit of a no-brainer, but sometimes people, they feel more complex than they really are. Most people with learning disability need easy read documents, myself included. Some people have visual impairments, they also need information in Braille or large print. Some people don't have English as a first language, so what language might they need? Do they have a physical need where you're going to need to look at hoisting or ramps or so on? Do people get very anxious? Do people get very nervous? Do they have sensory overload? Is there an element of autistic traits there where people might need some adjustments around that? Most people with learning disability need a longer appointment. And because it's an individual thing, there's a space there for people to write what their actual needs are. So you'd be pleased to know we're getting to the end now. Area of improvement number 6 is about identifying training needs for the whole practice team. Any training need for any member of the team. So whether it's just raising awareness of what learning disability is for non-clinicians, or specific training around what a reasonable adjustment is, because there's lots of mystery around that and it's really not that mysterious. Or is it more specific clinician-based training on subjects like the Mental Capacity Act, gaining consent in the correct way, how to deliver a proper annual health check, or increasing screening uptake and INS? So the SMART aim is really just to identify those training needs and share it with the relevant person or relevant organisation. In Leeds, for us, it's the CCG and the LD Health Facilitation team, so that we can arrange some training. It can be done either en masse as a target session, or in a slightly smaller groups in your PCNs or your members meetings, or on an individual practice basis, virtually or face-to-face, depending on what the pandemic's doing to us at that particular time. And personally, I prefer face-to-face, but we're all getting used to virtual, aren't we? That's for sure. So you'll be very pleased to know this is the last slide. In the centre of the slide are the contacts for our health facilitation team. I'll just tell you a quick bit about the health facilitation team. It's run by a senior learning disability nurse, Julie, who's also the strategic manager. We have Emily, who's a learning disability nurse, and we've just recruited Anne-Marie, who's not on the picture, as another learning disability nurse. The chap in the centre is Dean. He's our part-time graphic designer who puts all our learning disability documents that we very roughly put together. He makes them look good, and he brands them all so they're very recognisable. The green square with a little man inside, it's well recognised in Leeds by service users and carers that if they see a document with that on, they know it's from the team and they know it's something for them. We've got a full-time administrator who's lurking in the background of the photo there, Natasha, without whom none of this would happen. And there's a photo of me, sadly. If you do get a chance, or you do want to look at the website, the address is there. But to be fair, if you don't remember that, just put "Get Checked Out Leeds" in your search and the website pops up straight away. Click on the green download the resources button and you'll come to a page that's full of tabs like the ones on the bottom in grey. Under the Doctors tab, if you click on that, a load more tabs will come up. The top two are Annual Health Check and the QOF QI, and that has all the documents that I've explained and gone through today, and lots more. And to be honest, there's so many other resources there. I had to list down because there's so many different tabs. There's tabs for carers, about dentistry, diabetes, podiatry, opticians, screening and IMS, reports and legislation, and a really good one on COVID. There's easy read resources about COVID, about having a test, how to do a test, mask wearing, vaccination consent forms, and we've just added a vaccination booster consent form as well, given that we're just about to start boosting everybody. I will stop there, and I hope I haven't spoken too fast.
Not at all, Sam. That's utterly comprehensive. Thank you so much. Yeah. It was so comprehensive, in fact. I'm not going to spend much time talking about the summary. You've heard a refresher of the module. Sam's given us some wonderful examples of sort of local strategies they've used and how to interpret this particular module and how they're doing it. I'm going to go straight to the questions and answers, if that's okay. Because I'm not sure if you can see this, Sam, there's 50 questions or so.
Oh, wow.
We've answered 11 already. And so there's another 38 that are open. And now I'm assuming I am a bit of a novice when it comes to Zoom. I'm using Microsoft Teams an awful lot at the moment. So I'm not sure whether all of the other participants can see all of the questions. And I wonder, Sam, whether you can see them yourself. If not,
no, I can't see them.
I'm going to just try and rattle through as many as we can in the next 10 minutes, if that's okay. And there are some duplicates. And I think in your final 2 slides there, you did sort of say that the Get Started website is it's brimming with resources, and you just listed about 15 of them there. So I think that answers many or some of the questions already. And I'm just going to go. So we've had a lot of people thanking you as well. So thanks to everybody watching. So if I could perhaps just pick a few that I jotted down. So Kim Law at 7:01 said, so she's LAC for leader in Durham. They've completed over 150 reviews last year, and she agrees regarding the importance of the quality of the health action plan. And the reviewers have not even seen one good example of one. So they think that there's massive missed opportunities. So do you have any particular advice or tips in how to complete a good health action plan? Which template are you using? And do you ensure that these are shared? Or can you ensure?
Yeah, what I don't like about using the template, as much as the template and the recommended one that the RCGP documents, is that it doesn't produce a health action plan that's particularly good for the patient. It's okay for our point of view. And I don't think health action plans need to be that complicated. It can be something as simple as, I don't know, patient has earwax. You know, an action plan would be olive oil drops, you know, something really, really simple and straightforward. I think the important thing is to try and develop an easy, quick link to an easy read version of the health action plan, which we're just going to update our template in Leeds. So it's a one click. When you're on the template, hyperlink to an easy read version, and then you can just populate it in nice big font. Yeah. What I've tended to do personally is log one on the computer with using the template and then write it out separately for the individual. It's not perfect, but it's better than nothing.
No, absolutely. And if practices aren't competent or confident in, using hyperlinks or adding them to templates, then of course somebody else in the PCN probably will be able to, or your neighbours.
And I think the key is if you're going to make changes to templates, in an ideal world, have it done at CCG level, because if you make your own local updates, you create your own template in a way, you then do not access all the national updates. You will end up with a very bespoke version and miss out on some valuable update information.
Yeah. We've got 2 questions from Becky Scott and from Paramjit Dillon about who we should code. So Becky says, are you carrying out any work towards identifying the hidden population, i.e. those who are not open to services and who live independently? And Paramjit says, should mild learning disability patients get annual health checks as well?
Yeah, my belief is that everybody with learning disability should get an annual health check. Often people who are known to services or who are in supported living environments or in care homes, their health's actually quite well looked after, because the carers will take the onus and take the patient to the GP if they suspect there's a problem. People with mild learning disability, if we don't code them and we're not aware of them, they tend to be the ones that don't access services. So if they do come to surgery and you don't realise they've got a mild learning disability, you could be missing a trick. So it's a real opportunity. They're difficult to identify, and sometimes when people only have a mild learning disability, I think there's a reluctance from clinicians to label people as such, but just have that open conversation with them. And it's no different from being put on a diabetic register. It just means you're going to get properly adjusted access to care.
What about patients with traumatic brain injury, with new impaired cognition? I know you were quite explicit at the start about the definition. So is this something people should just look at, on EMIS, or System 1, or is there a glossary or a specific?
Yeah, as per the definition of learning disability, people with an acquired brain injury don't have a learning disability. That's not to say they don't have similar needs. So as far as the learning disability as is concerned, you can't do an annual health check and claim for a learning disability annual health check for that person, but you can still do the annual health check because that person needs it. So it's having an awareness. We will all have adults, some of us have care homes that we look after, don't we, for adults with acquired brain injury. It's not appropriate to put them on your learning disability register, but it is still appropriate to deliver the same level of care.
Yeah, of course. We have a couple of queries in regards to examination. And, if I can sort of just clump them together, you mentioned a full physical examination, and then someone sort of queried, why do we need to do a full physical? You wouldn't necessarily do a full physical, all the systems on, a non-learning disability patient coming in. And so somebody said, is it essential?
Yes, in a word. It's a requirement of the ES for a start. And I suppose I'm speaking from a slightly different point of view with my special interest. Why would you not? These people won't necessarily present with a breast lump. They won't necessarily tell you it hurts when they have a poo. It won't necessarily tell you that they've got blood in their urine. If you don't do a full physical check, and we're only asking once a year, you are going to miss some significant pathology. I know of a case in Leeds of a lady who, she was really unlucky actually. She was known to services. One of the learning disability nurses went in. She was independently living, so she was doing really well. And the person that visited her, I can't remember what the reason was that she went, but she went for something to do with her learning disability. And noticed there was blood on her slippers, and she said, "Oh, there's blood all over your slippers." She said, "Oh yeah, I bleed, but don't worry, it stops when I sit down." So that'd been going on for ages. These slippers were covered. She ended up having a kidney tumour, and this lady also had a breast tumour, and she'd never had an annual health check, and nobody had ever put a hand on her tummy or on her, examined her breasts. So I think we're doing people with a learning disability a huge disservice, and we will miss significant pathology. And I wouldn't like to sleep well at night if I'm thinking that I haven't done a full physical examination.
Thanks, Sam. Thanks for emphasising that. I think it's quite clear. I don't want to open a can of worms, but at your practice, how long do you allocate for a health check?
40 minutes.
40 minutes. And is that always with a GP, or do you have additional members of your team?
In my own practice, I've done it all, but I appreciate that's not always feasible. And I know lots of practices who the patient will have the first bit of the process done by the practice nurse, which is great, the height, weight, blood pressures, that kind of thing.
Yeah.
But because I got to know my patients quite well, I could actually get that appointment time down to about 30 minutes, because you build a relationship with them. So it needs to be a decent length, and don't think you have to do it all in one appointment. You know, I have been known to chase somebody around a room just to get a blood pressure for 10 minutes. Sometimes you need to revisit these things and build that relationship. It might take you a couple, 2, 3, 4 annual health checks to complete the annual health check, but at least you're building a relationship. And should that patient then need to access primary care for an urgent problem, they understand the processes, they know the people, it's familiar environment. You're not going to have people kicking off in the waiting room because they don't understand and they're scared and they're frightened.
Yeah. Can I ask maybe 1 or 2 more? Do we have time? So one of the questions is in relation to capacity. So I think they're a little bit anxious about whether they have to, our GPs, are we responsible and expected to address the large number of capacity assessments, or is this undertaken by the LD specialist teams?
As GPs, you're responsible for making decisions around capacity for interventions that you might be undertaking with that person. I think that's the easiest way to look at it. We can't possibly in primary care be responsible for all capacity measurements. That's not a thing. But if you are looking at flu jabs, if you are looking at screening, if you are looking at COVID vaccination, and you're actually undertaking those interventions in primary care, cervical screening, for example, bit of a can of worms, that one, for people with learning disability. But you know, if you are looking at delivering an intervention, you are responsible to assess whether that person has capacity. And it's not difficult. When I first started getting interested in all of this, I thought it was really scary and really too much like hard work, and it's not. It's really quite straightforward.
I think we're gonna, I'm hearing in my earpiece that we have to wrap this up. So Sam, thank you so much. We've got lots of praise on the question and answers. We're going to have to close the Q&As at the moment, if that's all right with you. One of the questions that keeps cropping up is, can we have the slides, please? So I'd like to confirm, yes, of course. The slides will go out to everybody after this presentation. I think our project manager, Joe, probably wants to get some sleep shortly. So maybe this will happen tomorrow. Other questions will be, we will try to address all of the questions that have cropped up. Again, probably won't happen tonight, but we'll endeavour to get back to you and compile these and get back to you as soon as possible. They won't be ignored. So we'll send the responses out to everybody, and it wouldn't be a proper webinar if I didn't ask you all to complete the short evaluation questionnaire to let us know what you thought of the webinar and Sam's presentation. I also need to say, or just to remind you, that there is another webinar scheduled for this time next week, and that's on the early diagnosis of cancer. And again, it's searchable on the RCGP events page, and links will be included in the evaluation email. There's also podcasts that we've done, one for the cancer module and one for the learning disabilities module, and they are available wherever you download your podcasts normally. And then in addition to these resources, there are more case studies that we've done, some top tips, we've created some PCN guidance, and they are found on the RCGP QOF QI webpage and on QI Ready, and links will be shared, as we said before. So thanks again, Sam, and thanks to Joe in the background, and thanks especially to you, the participants, for joining us today. I think there were 500 odd people. It was a pleasure, and we look forward to seeing you at the next webinar.